These are the objectives that are outlined in the syllabus and in the brochure. We're going to go through the National Disaster Response functions, how the different offices and departments work, get a little bit familiar with the National Disaster Medical System, and then kind of focus down on the level that I mainly deal with, which is the Disaster Medical Assistance Teams, which is sort of the workhorse of the system. Anytime you're doing a talk about the government, it's full of acronyms, lots of initials, and things that stand for things, and sometimes I don't even know what they stand for. I think that's the government's way of kind of keeping us in the dark on what they're doing with their money. That's sort of my personal opinion. But if I start speaking in a phrase you're not familiar with, please let me know. I'd be happy to, if I can, remember what it stands for. But basically we're talking about the Health and Human Services, or HHS, which we're all pretty familiar with. It's that branch of the federal government that's responsible for protecting the health of all Americans and getting our essential human services. There are 11 operating divisions, and in 2006, President Bush signed the Pandemic and All Hazards Preparedness Act. You all remember when pandemic flu was like the big thing. We were in endless meetings about pandemic flu. And that's when this office, the Assistant Secretary for Preparedness and Response, was created, also known as ASPR. So that's the division that we're now under. So we've gone from HHS to ASPR. The mission of ASPR is to prepare the nation to prevent and respond to health effects of disasters, be they natural or man-made. And their vision was to create a country that was prepared to prevent and respond to these health effects. The goal to increase the capacity of our system to respond to public health threats, again, whether man-made or naturally occurring. So some of this was in response to 9/11. Some of this was in response to all of the hurricanes, and we decided we really needed to get a little bit better at it. Before ASPR, as a way of history, the National Disaster Medical Response System all existed under FEMA. And as it has since transitioned out from FEMA to Health and Human Services, which in some ways is good because Health and Human Services is really focused on health and FEMA is focused on such a large thing. And in some ways it's bad because FEMA was really an agency that was very prepared to deal with emergency situations and poor conditions. So there's been a transition. What does the Assistant Secretary for Preparedness and Response do? Well, basically, they coordinate with the Secretary of the Health and Human Services. They direct and coordinate those activities. They interface with a lot of agencies, including Homeland Security, including the World Health Organization, or WHO, including Red Cross, and things that we call NGOs. Now, when you work for the government, NGOs is a bad word. It's almost 4 letters. When you don't work for the government, NGOs is a good word. It stands for non-governmental organizations. Wonderful non-governmental organizations out there. Southern Baptist Convention. They send mission people all over the place. Lots of churches. Doctors Without Borders. Some really great organizations fall under this title of NGOs, just to give you an idea of what we're talking about. So, wow, finally somebody had a brilliant idea that maybe the government should be talking to these people so that we can coordinate things. And that was one of their goals, and they're starting to work on that pretty well. ASPR has 4 offices, as you can see. We're going to be focusing on that last one, which is the Office of Preparedness and Emergency Operations, or OPEO. Here's the organizational chart. I'm not sure, is there is, oh look. So basically, here's the ASPR. This is all the divisions. Here's the OPEO, and eventually we're going to be focusing right down on this bottom one here, which is NDMS, standing for National Disaster Medical Services. So here you go. And this is just one of the 11 divisions of Health and Human Services. It's great, isn't it? And under here are umpteen million more divisions. The responsibilities are basically, the OPEO is the lead agency. It prepares folks. It works within the ESF-8 that we may have learned about when you've done your NIMS or ICS training or HICS training with your hospital. You've probably heard that phrase, ESF-8, Emergency Support Function 8. We also work under the Homeland Security Presidential Directive 10. That was the big one that was created after 9/11. They are to integrate the mass casualty preparedness within NIMS and the National Response Plan. Now that may sound like something pretty straightforward to do, but wow, that is a big big undertaking. You know, now taking place in Alabama. Once the declaration of emergency has occurred and been approved by the federal government, all of these things start rolling into place, and it's pretty tricky. As we saw after Katrina, lots of lessons learned there, lots of nightmares. It's not that easy to connect Uncle Joe and Aunt Sally with their lost dog, trying to retrieve their lost bank account, and find the rest of their family members when all of these things are in different places and have been destroyed. It's a very, very large undertaking. The Office of Preparedness also manages and trains the Incident Response Coordination Team, or IRCT. They're basically the ones that direct which teams are going where and doing what, whether it's search and rescue, whether it's medical aid, whether it's emergency veterinary care, whether it is mortuary care. All of that is coordinated by the IRCT. And they also manage NDMS, National Disaster Medical Systems, and something called an FMS, a Federal Medical Station. A Federal Medical Station is operated by the Public Health Service and is basically a temporary, longer-term care facility to care for folks who've been displaced from a nursing home that may have been destroyed, from a rehab center that may have been destroyed. These people have to have some place to go. But the Disaster Medical Assistance Team is really more set up for emergency care. So we've got to have something that takes care of these folks who need longer-term care, and that's what an FMS is. Okay, now we're down to, this is the part I wanted to talk about. I got all that other stuff out of the way. We're trying to talk about now about National Disaster Medical System. Cooperative asset-sharing partnership that leverages federal and other resources to care for a large number of casualties from a disaster or overseas conflict. One of the things that the government put in the fine print of the missions and duties and goals of the NDMS was to care for overseas casualties from a conflict and to supplement and backfill the VA. I don't know how they snuck that in, but they did. It's this one little blurb, and you think, holy crapola, that is a huge undertaking to put in underneath everybody else. And so that does fall under them. They do operate under Emergency Support Function 8. They administer a network of member hospitals and are backup to military and VA hospitals if there's a military health emergency. Luckily for us, the military systems, and I come from that background, I see several folks in here I know who are previous military as well, they're pretty well set up to handle their own mass casualties. And so that's not going to hopefully be a big issue for us, but boy, if it was, it would be kind of frightening. It would be kind of frightening. This comes straight from the web page. If anybody ever wants to surf around Health and Human Services web pages, you can eventually find a whole lot more information. And I'm going to blow up a few of these sections. Federally coordinated system that augments the nation's medical response capability. The overall purpose of NDMS is to supplement an integrated national medical response capability for assisting state and local authorities in dealing with medical impacts of major peacetime disasters. And then, of course, that other piece I just talked about, which is providing support to the military and the VA if you have mass casualties being evacuated back to the United States. And that would have to be pretty mass casualties, because the military hospitals are huge, so I can't see that happening. Again, just reviewing, part of HHS under OPEO, under the ASPR, under ESF 8, etc. All of these federal things that basically federally declared disasters, you're eligible for all this aid, whether it's natural, whether it's a major transportation accident such as an airline crash or train crash, cruise ship incident, something like that. Technological disasters, you know, God forbid what happens in Japan happens here, and we have a nuclear plant just down the road, very, very close by, and something goes wrong. And including acts of terrorism, including weapons of mass destruction. So that includes a dirty bomb, that includes bioterrorism, anthrax, all those wonderful things that we heard about a lot in the years following 9/11. Kind of a regional map. We are currently in Region 4 under NDMS. Most of the stuff that we get actually comes out of Washington. It seems to be that we're coordinated more out of Washington than out of Atlanta, but Atlanta is sort of designated as the hub for our region. The vision is to serve the federal response by providing disaster medical care to the nation. That includes everything from tornadoes in Alabama to earthquakes in California to floods in the Red River Valley and Ohio River Valley last year, to the 4th of July on the National Mall, etc. It is a temporary assignment. It's designed to be temporary. It's specialized, it's focused, and we provide disaster medical, mortuary, and veterinary care. And that is important that we emphasize those two things, especially mortuary care, because when you're dealing with lots of casualties, you're also unfortunately dealing with lots of mortality, and those bodies do need to be handled appropriately. So this is an example of a DMAT supporting an existing facility. And Paul, I think you told, I know this is Massachusetts 1. You think this was Katrina? I've got so many pictures, I can't remember which is from which, but I think that this is a fixed facility that was damaged during Katrina. A DMAT goes in, they set up their temporary tents outside. They've got their generators, they've got their own power, they've got all of these things, and they're able to supplement that hospital. So in other words, the hospital will still have some of its personnel, but maybe their homes have been damaged. Maybe they've had loss of life or loved ones or injuries that they need to care for. As you all know, when a disaster hits an area, people don't come into work and they need a little help. So this is kind of an example of one type of mission that an NDMS team might do. So we send personnel. Sometimes we just send personnel. A hospital may call and say, wow, we've been really decimated. A lot of our folks have had personal loss. We need bodies. So physicians, nurses, PAs, respiratory therapists, pharmacists, EMTs, paramedics, we will just send the bodies. We will send the folks to do the work, and we don't send anything else. Sometimes we'll send a team of people. Sometimes we'll send supplies and equipment. Sometimes our main focus is to help them get the folks moved. How do we get all the people that showed up at Charity Hospital in downtown New Orleans the heck out of there to someplace else? Because there's just so many people that can be seen at one hospital. And then sometimes we do provide definitive medical care at these participating hospitals in the unaffected area. So if you've been designed to receive a bunch of casualties from an area, maybe we should send some disaster medical assets to you to help that, because now we're asking your hospital to take on 5 times its normal workload. Gee, wouldn't it be nice if the government also sent you 5 times more bodies? Did I not do? So for example, this is the airport claim area. I believe this is during Katrina, transporting folks, trying to arrange for transport of people out of the area. Where do they need to go? To what hospital? To what area? You have to coordinate with where do they maybe have contacts, where do they maybe have family. You have to coordinate with what hospitals can take who, what kind, how many, which type of physician, patient. So under NDMS, we have 4 teams, or 4 types of teams. We have a disaster medical assistance team called a DMAT. We have a national veterinary response team. We have a DMORT, which is mortuary operational response team. These guys are great. These are morticians and funeral home directors who volunteer to do this work. They do a really phenomenal job under really horrible, horrible conditions. And then we have the International Medical Surgical Response Teams, or the IMSRTs, that are a more subspecialized medical team that's designed to go internationally. The others are designed to stay in the United States. Punta Gorda, Florida. This was, I think, Hurricane Charlie. And this is a DMAT that's just kind of set up in an open area there to start responding to casualties or whatever their mission assignment is, and the mission will come down from the chain of command using all those chain of command things we learned through NIMS and HICS. This is your DMAT. We are from the government. We really are here to help. I have to emphasize that, because sometimes, you know, you're from the government, you're sort of suspicious. This is a picture of our team that went to Haiti. Paul, where are you? You're in there somewhere. Paul is in there. That's me, curly locks. You can always find me. More humid, the more curly. There you are. There's Paul right there. Paul is sitting in the back in the orange shirt there. He's Here's my cheering section. So what is a DMAT? A DMAT is a group of professionals and paraprofessionals in the medical service. And I think I've already told you, doctors, nurses, paramedics, RTs, techs, pharmacists, pharmacy techs, surgical techs. It's supported by a logistical and administrative staff that's all on the team as well. So you've got somebody who does your IT, somebody who does your communications. I heard a question at the end of the last session. We travel with our own communication set, usually a double system. We have both line of sight as well as a long distance communications. We do take cell phones, but we have found that in most places the cell phone towers are gone. And it's hard to charge your cell phone in a tent. It can be done, but it's tricky. So we have all of that support staff that comes with us, with our laptops, with generators, food and water. We're designed to provide medical care during a disaster, and we respond to mass casualty incidents on local, state, or federal basis. That was the initial design. And then came Haiti. Haiti was the first international deployment of a NDMS asset, of a disaster medical assistance team. And we deployed a bunch. We deployed several and then rotated them out. It was a very, very interesting experience. I have a whole other talk on that if you ever want to hear it. Lots of cool pictures. We try to keep the whole DMAT at about 130 employees. And the reason is because you're deployed usually in a group of 35. And if you have 130 people on your team and you need 35 people to say, okay, I can go somewhere for 2 weeks, your chances of getting the right 35 people actually, in the air on their way to whatever are much higher. So we're constantly trying to keep our numbers up high. It also makes it a lot better for everyone else on the team. More people you have on the team, more workload is shared. If there's a time where I can't go on this particular mission because something's come up with my family or myself, then there's another person who can step in and fill that role. A DMAT, you are an intermittent federal employee. You go for up to 14 days, anywhere within the, quote, federal domain with licensure reciprocity. So when we went to Katrina, we were all magically okay there because we had a federal license. When we went to Florida, again, same thing, Alabama, Mississippi, California, Haiti. I don't know how we magically got an international license, but we did, and you're covered. You're also covered under Tort Claims Act, the Federal Tort Claims Act. You also have workers' comp coverage, and when you get deployed somewhere, you go on federal wages, which is, of course, not the same as private practice wages, but they're really not bad. They're really not bad, I have to say. Considering that you're volunteering to do this, to get paid to volunteer, it's not a bad deal, not a bad deal. Members of a DMAT are also protected by USERRA. USERRA is that government regulation. Please don't ask me what it stands for. I don't remember. Something uniformed services, blah, 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 blah. It basically says if you get sent somewhere because your DMAT got deployed and you have to leave your practice, your hospital, your job for 2 weeks, they cannot fire you. It's like National Guard. If you have National Guard duty, you're protected by USERRA. It's the same law. All of the equipment and supplies for a DMAT team are standardized. What that means is, for instance, last month I was supplementally attached to a team out of Washington, D.C. for 2 weeks because they were a doctor short, and I was going to deploy with equipment out of Maryland. I've never seen the equipment in Maryland. I don't know what I would be working with, right? Wrong. Every team has the exact same setup. The exact same equipment, the exact same tents, the exact same products. They're all packaged in the exact same containers with the exact same inventory lists. So I can go anywhere in the country with any of the 170 teams that exist and always get my hands on the same thing. Now, is it the stuff I necessarily like? No, but it's the standardized stuff. I know what I have to work with. 2008, I want to say this might be Texas, this might be Ike. Again, you can see they'll set up a DMAT anywhere. Here's the Sports Authority, if you want to go shopping. We're right here in the parking lot on this particular case. Again, these are the prepackaged supply kits that are all inventoried the same. We're self-supporting. A DMAT is self-supporting. We travel with tents, generators, litters, food, water, medical equipment, supplies, drugs. Yes, even controlled substances. And magically, the DEA is also a federal agency. Isn't that nice? We all work together. And we're supposed to be able to go for 72 hours without resupply, and that includes in personal care of self, food and water for the team members. I didn't tell you what kind of food, but there's food. It's not the best food. Although I have to say the South Carolina DMAT is blessed in that our chief logistics officer is also a champion barbecue chef. So we always find room for the barbecue grill in the trailer somehow. I don't know how that is. So here's just an example. This is a Florida 1 DMAT team. They're loading up their standard trucks. We all have the same trucks with the chests of supplies and the crates of lighting and the crates for the tents and all of these other things, getting ready to deploy from their warehouse. I believe this is Massachusetts 1, and this is in Haiti. I can tell that because everybody's absolutely sweaty, soaked through. But they have a fan. We don't have a fan in our packing list. We need to acquire that. Okay, so the federal definition is that we're supposed to be a rapid response element. We supplement the local medical care until they get something more permanent in there, whether it's a contract resource, another federal asset, or the place you're supporting gets back on its own feet. So it's temporary. We go to be self-sufficient for 72 hours. We can do anything including triage. We provide austere medical care. We're not set up to do big complicated things. Yes, we can intubate people. Yes, we have ventilators. Yes, we have cardiac monitors and those types of things, but that's pretty resource draining. So we don't do a whole lot of that. And a whole lot of evacuation prep and assistance, getting people the heck out of there. You don't want to be doing care in a tent for a long period of time. You really want to stabilize them to get them the heck out of there. Primary and acute care, triage, initial resuscitation, stabilization, ALS, and prep for transport. We are required to be mobile within 6 hours of notification and designed to arrive within 48 hours, be up and going. And the only reason they give us 48 hours is it usually takes us, we're supposed to be mobile within 6 hours, but it usually takes them that long to even find us an aircraft to carry everything, to get somewhere. And then we have to set everything up. This is Haiti. When you're out of country, obviously you don't have all your same stuff you're used to. You don't have highways, you don't have planes, you don't have things you're used to. So this is a pickup truck. This is me. And we're loading up. There's a litter patient in the back here. This is actually a head injured child in the hands of one of our paramedics from the team. And that's it. We're transporting. We're transporting out to a helipad to get these folks to more definitive care. Again, here we are loading up a helicopter. These are our SC1, South Carolina 1 DMAT members doing that. That's in Haiti as well. This is our typical, as you can see, everything is pretty much represented, including security. Very important, especially if you're someplace where disaster has struck. People get real antsy. People like to acquire things they think they need to survive. You know, what they think a walkie-talkie will help them with, I'm not sure. But, in Katrina, they stole TVs out of the stores when there's no power. We follow the IC guidelines. There's an incident command system. It's pretty standardized across the country. I know that everybody's had at least the basic introductory course. That's pretty much a requirement at most facilities these days. We do this. As I've already told you, we can backfill local hospitals. We can do pretty sophisticated pre-hospital care. We can staff casualty collection points. We can do outreach and community assistance. One of our second deployments to Katrina was to administer vaccine. Was it flu? What else did they give? I can't remember if it was typhoid or something. Hep A, Hep B. Dr. Pace is on the DMAT, by the way. Went with me to Haiti. So here, this is actually a photo from Haiti. You see that we do interact with other agencies. These are the Marines. Our security in Haiti was the 82nd Airborne out of Fort Bragg. So we do work with other folks. We also work, like I said, with the NGOs when we have to, Doctors Without Borders, the Israeli hospital system. They all had nice groups down there. Just an example, you know, everybody knows about hurricanes. Hurricanes and earthquakes, everybody knows about, but ice storms, floods, especially things like that allow for a little bit of pre-staging. If we know there's a hurricane coming, they will often send us someplace and park us in a hotel about 100 miles from the predicted hit zone, and we'll sit there for 3 days and wait. And invariably when that happens, the storm changes course and then we all go home. And when they don't pre-position us, then it's kind of, oh, hurry up, get down there and get where you need to be. We do national special security events. We did have a team at the Olympics in Atlanta. We State of the Union, inauguration was a big team. Republican National Convention, Democratic National Convention, 9/11, the anthrax attacks. We had a team last summer, strike team from DMAC, go up to the National Mall in DC for 4th of July, just to sit under tents and sweat and give out a lot of water. How does it work? Basically, there's a lot of teams across the country. There's a rotating call schedule. Your team's on call usually 3 different months out of the year. And you're on a backfill if you want to be on the 4th month out of the year. You get notified, you get alerted, and then you get activated. These are all sort of technical terms. Once you're activated, you're on the payroll. You have to follow certain codes of conduct, obviously chains of command. Safety and security is paramount. Your expenses are all covered. Every expense is covered. Plus, they usually give you a per diem. They gave us per diem in Haiti, which I thought was hilarious. What are you going to do with per diem in Haiti? There's no hotel. There's no restaurant. So you can get the money. Obviously, it's not bad to have. Your 14 days that you are asked to deploy with the team does include your travel days. So if it takes you 1 to 2 days to get there, 1 to 2 days to get back. So it's not that big of a time commitment. It's really not. You have to be expecting to work in very austere conditions without any privacy. You're living in a tent with everybody else on your team. Okay? It's not pretty. You're going to be working at least until you get to know the people on your team. You're probably going to be working with people you don't know. Sometimes that's a lot of fun. You learn things. I know I learned a lot. We deployed with a pediatrician out of California, and I learned a ton from him. He was an awesome guy. There is some physical elements involved, setting up tents, carrying litters. As you can see, this is Haiti. It's hot, sweaty, buggy. Carrying. This is the toilet. That's a bucket, a 5-gallon bucket. This one's actually nice because somebody put a rim on it. Some of them don't have. This is pretty austere, I have to say, even though I took a picture of this. Just behind this big trailer over here were real porta potties. And we actually do have access. We bring our own sinks so that once we find a water supply, you can kind of wash your hands and splash your face. You obviously want to brush your teeth with bottled water, but nobody used this. I just took the photo because I thought that's the worst it could get. I am getting really close here. We'll kind of skip some of this history stuff here and go into the SC1. There's only one DMAT in South Carolina. SC1 is it. It was organized in 1990 by Charleston County Medical Society. They took their equipment from a 1960s area hospital that got destroyed during Hugo, and everybody was a volunteer. This is a picture of the team that went to Katrina. These are some other places we've been to. You can see the G8 Summit, Haiti. We're always looking for providers. We currently have 5 physicians on the team, 5. And only 3 physicians on the team are what we call deployable. The other 2 are kind of honorary members that help us out with the training and other things, but they're not physically able to go on deployments. That's 3 doctors. Every team that goes someplace has to have at least 2, preferably 4, to go somewhere. So, and the more doctors we have on call, the less often you're on call. Same as in your private practice. If anyone is at all interested, if this sounds like something you want to do, you might even get your picture taken with famous people. This is Randy Lindstrom. He's out of Hilton Head, isn't he? He's a paramedic out of Hilton Head, and he worked the airport there in Haiti and got his picture with Anderson Cooper, and he got his picture with John Travolta, and he got his picture with a bunch of other people. And we started to wonder what the heck he was doing out there because he came back with all these pictures. But if this sounds like something that's a nice way to do some aid work, some mission type work, However, you're so well protected within the federal system, which is a little bit different than when you volunteer with some of these other agencies. You're well protected with tort form, workman's comp, all your travel, all your meals. You get a little bit of money on the side, great deal of satisfaction. These are all type A people. There's no lazy people on a DMAT. That's the wonderful thing about it. There's nobody who sits back. So we are always looking. Paul in the back does have a little handout if you are interested and want to know more. I've also got some business cards up here. Here's some contact information as well. But yeah, if we get a few more doctors on, then we could all be on call a lot less. Okay, I think I'm out of time.